It's my honor and privilege to introduce Dr. Rajalakshmi to us. I thank Dr. Thomas Cherian for suggesting Dr. Rajalakshmi's name, because initially when I thought of this IC, I honestly didn't have her in mind, but that is my loss anyway. So Dr. Rajalakshmi heads the medical retina department in Mohan Eye Center in Chennai, and can you ask them to put that slide? 13B. She also heads research in the same institute, and she's got a passion for ophthalmic research, and her main interest is cost-effective screening for diabetic retinopathy. And her focus of interest is retinal imaging, teleophthalmology, and artificial intelligence in various retinal diseases. She has been the principal investigator and co-investigator in many international projects and collaborated with a lot of eye projects. She is also a section editor in the Eye Journal of Medical Retina and a prolific publisher. She has over 70 original articles to her name, and it is really an honor to have her here and help us understand what we can take home from this study. We all know it's important, and the papers were very difficult to read and comprehend, but since Dr. Rajalakshmi has been in the entire thing from the beginning, so over to you, Dr. Rajalakshmi.
Thank you, Dr. Sheena. Thanks for your kind introduction. And at the outset, I would like to thank Dr. Sheena, for inviting me, and Dr. Thomas Cherian for suggesting, and Dr. Sheena for inviting me for this excellent academic session. It is true that the Smart India study happened involving all the doyens of ophthalmologists across India, and it is a study which has not been discussed enough in any of the ophthalmology conferences in India, and thanks for initiating this. I have no conflicts of interest or financial disclosures. As Juhi rightly said, Dr. Shobha Shivaprasad is also from Kerala. She did her MS ophthalmology in Kerala only, and then she moved on to Moorfields, and she got us this 6.3 million pounds grant, and out of which we got about 20% coming to India, which helped us do this study. Work package 1, Smart India study, is what we are going to be talking about in this session. Juhi has already shown this nice map of 20 sites which were involved in this study. And this was a study which did a cross-sectional population-based study. It's easy to do a clinical study. Doing a population-based study is not easy at all, to study the burden of diabetes as well as diabetic retinopathy across the country. It was also to assess regional-wise prevalence of the different complications, including retinopathy. So this is the protocol which Juhi explained so clearly. So I can skip this slide and move on to my topic, the burden of undiagnosed diabetes and suboptimally controlled diabetes and the associated risk factors. So in this Smart India study, it was conducted in people above the age of 40. And what was done was, a one-touch glucometer. So by the one-touch glucometer, if they had diabetes, the blood values were noted. If they had one-touch glucometer value of above 160, many of you may have people at home with diabetes who have a one-touch glucometer at home. A new thing which was used was, usually HbA1c or glycated hemoglobin is done by blood test from a venous sample. This was a study which used a point-of-care kit, which is so simple and easy to use that even at the home they could check the 3-month average sugar control, that is the HbA1c or glycated hemoglobin. And if that was above 6.5 also, that also turned out to be a way to diagnose HbA1c. Okay, so this is a pictorial description. They took how the field workers were so actively involved. They took the anthropometry measurements, they checked the blood pressure, their weight, height, and then the random blood sugar. And then there was, if they did not have diabetes, they were just given the parameters. They had diabetes, then they underwent all these tests. You can see the A1C. This is a point-of-care kit. This was again a point-of-care kit to analyze the lipids. And those who had retinopathy, they were told why they are going to undergo a photograph. They used a simple handheld camera and took pictures of the patients in their own homes. We all struggle to take pictures in the hospitals. These were pictures taken in the homes. And you can see that in the Smart India study, there were already about 5,689 people who declared that they had diabetes. But through the study, there were again 2,221 people who were identified to have diabetes, who did not know they had diabetes, and they were newly diagnosed to have diabetes through the study. So I'm going to take you through these results. Because when we speak so much about India as the diabetes capital, it is not something to take pride of, but we have to remember that it is a big burden to have a non-communicable disease like diabetes, because that will lead on to other complications affecting all parts of the body. So in this, what we found in particular was, earlier we thought that diabetes can affect only the urban people and rural people are not affected. We were right in the sense that known diabetes was higher in the urban areas at 17%, and rural areas it was only 9%. Whereas if you look at undiagnosed diabetes, the percentage of undiagnosed diabetes was 6.1%. If you see 2,200 people out of the 7,000 people, which means 30% of the people did not know they had diabetes. If they don't know they don't have diabetes, if they did not know that they had diabetes, how will they have their eyes checked for retinopathy? How will they go to the ophthalmologist for further eye assessment if they don't even know they have diabetes? And what is important to us as South Indians, people from Kerala and Tamil Nadu, is that the South has the highest prevalence of diabetes. See, 19% of known diabetes, 7.8% of undiagnosed diabetes, so 25%. We had the highest prevalence of diabetes. So we need to be, the government of India has to give more importance to the south states where the prevalence of diabetes is higher. So if you look at the risk factors, we are all aware of these risk factors. Again, obesity being an important risk factor, increasing age being important risk factors. Dr. Mahesh told about the ETLs. That is the better to do states like Tamil Nadu, Kerala, Karnataka, the better doing states. The better doing states have more of diabetes, more of hypertension. So people at the higher ETL states had higher risk for diabetes and other things. Again, higher cholesterol levels. These are all added. But what is important for us to know is, how is the sugar control in our patients? Whenever our patients come for cataract surgery or they come for diabetic retinopathy assessment, we check the HbA1c. But what is their control like? We talk to them only when, we found that randomly in the study, only 25, normally we all know that less than 7 HbA1c is considered to be good. When it goes above that, poor control is above 9. Only 25% of the people, whether it was urban or rural, had a good HbA1c control of less than 7. More than 40% of them had high HbA1c, which is equivalent, which caused retinopathy. Here you can see that when the HbA1c is above 7, the percentage of retinopathy goes odds is 16%. When it is above 9, 21% had retinopathy. Even the vision-threatening retinopathy goes up, increases by 4 times higher risk for sight-threatening retinopathy when the HbA1c is above 9. That's the importance of glycemic control. So if you see that in this study, what we found is, any person with diabetes, BP should be less than 140/90. LDL should be less than 100. We say when there is macular edema. HbA1c, only 25% had HbA1c less than 7%. Irrespective of the age, whether it was rural, urban, male, female, HbA1c control was very poor. We have very poor glycemic control in India, which is a very sad state of affairs. It could be that there's lack of exercise, everybody is seeing the mobile, no physical activity being there, etc. If you look at even people with longer duration of diabetes, their control only 20% had good glycemic control. In fact, even illiterates or literates, everybody HbA1c was quite bad. So poor glycemic control is a major risk factor for all microvascular complications, kidney disease, heart disease, retinopathy, everything. So to conclude, the prevalence of diabetes is 18%, known diabetes is 13.5%. The prevalence is highest in South India. The prevalence of diabetes is higher in men. Known diabetes prevalence was higher in urban areas. 30% of them did not know they had diabetes, whether it was urban or rural. 75% of the participants had suboptimal glycemic control. 40% of them had very poor glycemic control, HbA1c greater than 9%. These are the patients whom we treat. And it is important to emphasize glycemic control to reduce the burden of diabetic retinopathy. Thanks for your attention. And I would like to show, this is the Smart India team. Of all of us here, you can see Dr. Sheena here, Dr. Shobha Shivaprasad, and all of us here, the team which was involved in doing the Smart India study across the 20 sites. Thanks for your attention.
Thank you. Thank you, Dr. Rajalakshmi, for that wonderful talk. You made it very simple and very easy for us to understand.